Um, we will use various separating mediums in order positioning tools here to hold the mandible's cant in three-dimensional corrections. So you'll see that one is a round cotton tip applicator. We have a three-way syringe tip, and we also have one of these micro brush tips. They just have different diameters, okay, but they're all round. And they need to be round so that we can capture these three-dimensional corrections. Using a flat appliance of any type, Lucia Jig, using Best Bite, any of these flat surfaces, even an NTI, will create an artificial cant based on what, can you open just a little bit, based on whatever angulation of the incisal edges that that flat surface comes in contact with. However, a round object, no matter what the cant relationship of the teeth is, will hit at point contacts and be able to capture that without distorting it or creating something that's artificial. So now we're going to match these up to the rest point of the phonetic position. So now we're going to take a look and ask the person to speak and see how the mandible changes in this movement. Okay, so let's take a look at the habitual occlusion. Can I have you close together, please? Okay, and that's the occlusion. All right. Now we're going to ask you to count, please, and we'd like you to count from 66 to 77, if you would.
66, 67, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77.
Okay. We can see that as he was speaking. Can you do that again, please?
66, 67, 68, 69, 70, 71.
We'll notice that there's about ½ millimeter separation between the incisal edges in his speech sibilant phenome position at the S position that we're using. So of the three mediums that we would use to stabilize the mandible in this position, we would want to have the smallest, and we would use the tip of this micro brush here. Okay, so what we're going to do is we want to capture that and get the patient to stop in a position, an upward movement of that mandible, and capture them at a point that is the same diameter as our separating medium. Okay? So we need to time that, and we need to go through this, we need to practice. Now I'm going to ask you to go ahead and count from 66 to 77, and somewhere along the way I'm going to say stop. And when I say stop, I want you to freeze in that position. So it'd be 66, 67, 68, stop, and then just freeze just like that. Once you're frozen, I'm going to place this on top of your tooth there, and let me just show you what I'm going to do. I'm going to place it, go ahead and close on that, just like so, okay, and open. And then you're going to stay like that. Now I just want you to hold that position while and not move thereafter, because we're going to place some impression material between your teeth, okay? So it's important you don't move at that point, okay? So I'm going to have you go ahead and start counting.
66,
67, 68, 69, 70, 71, 72. That's great. Let's start over. 66,
66,
67, 68, 69. Stop. Okay. We'll try it one more time. We'll just do it. Just relax. There you go. And go ahead. 66, 67, 68, 69. Stop. And go ahead and just close on that. Okay. Maybe open just the tiniest little bit. A little bit. There you go. Just hold that position for me. Tiny bit more. There you go. Okay, if we can hold that position without moving, you can see that we have about the same separation as we did in the speech position. Now, it's important the number that you pick to hold the relationship. For instance, I had him stop at 69. And here it's important that you get the impression material right up against the teeth and that you inject this material all the way through so that you have a good bite relationship, so the laboratory will have a sound place to produce this orthotic, because the first thing they're going to do is take this to the lab and thin this bite relationship down, and if you don't have it all the way through, they won't have the stability. It's important that the assistant and the patient doesn't move during this process, and I only do one side at a time to reduce the chance of there being some kind of error introduced into the equation. Now, with this patient, because his problems are diagnosis in his situation are capsulitis, then I'm picking the 69 position. If this person had a discal ligament problems, elongation, popping, clicking, dislocation of the disc in the supine position, then I would actually pick the 66 position to give the optimal range of that phonetic position. You see, each of these numbers in this S position gives you a slight variance. Okay? Now we're going to hold that position, nobody move, you're doing great, terrific. Now I'm going to come to the other side now that that's set, and we'll take a look. And again, we will then inject over here, and you can see a slight change in that. There's a little bit of a cant change there. And up to the right here, a little bit greater posterior interocclusal space. Okay, we're going to let that set, and then what you do immediately after this sets is then you would check your autonomics, your reflex testing, to make sure that this position corrected that neurology. Because if it doesn't, there's not much point in taking an x-ray or doing anything. So now, with the bite registration in place, what we're going to do is we're going to see whether or not this corrects the neurology for this patient. So we'd like to see if we put you in the PCSD5 position, okay, and hold that. I'm going to apply a little pressure. We're going to create a stimulus to see if there's a reflex reaction, and now there's no response to that. It is no different than doing the other side, so now he's reacting as anyone would who had a normal TM joint without any pathology. We still need to know in this particular patient whether or not this, we don't need to check this at this point, but just to demonstrate the fact that this is a TM primary, we would ask the patient to now stand up. Okay? And we want to know if this bite relationship is now correcting these other deficits. May I have you put your hands in this position for me? Rigidly hold this, concentrate. And now he's solid as a rock. Okay? If we were to remove these, excuse me, there we go. Take these out. There we go. Some tissue for you. Okay. Super. Okay, we'll take them out. There we go. And let's go back and retest. So just hold position like so, rigid as can be, rigid as can be, okay. Rigid as can be. Okay, now I'm going to apply some pressure, and he easily fails. May have you sit down in that chair again towards the end. Don't let your back touch it. And let's try this PCSD5 test again. Hold this position. Okay, rigidly hold this. Rigidly hold it. And we're going to apply a little stimulus, and he easily fails. Let's try it again. Maybe he's got a bad shoulder. Doesn't matter. Let's compare. Okay. There we go. Okay, now he's reacting in that way. So you can see there's a dramatic response here, and now we know that the position that we have for this patient will make significant changes to his nervous system as well as to the proper structural function.